Now coming to the next important part, this is the most important part in case of the renal system, that is the tubular transport. Tubular transport of various substances we will study. Out of them, the sodium transport is very important. The sodium transport is very important. So we are going to pay more attention to the sodium transport. But before that, we will be discussing the tonicity. What is the tonicity in different segments of the nephron? So this is the classical structure of nephron, which we already saw. But right now we are going to highlight only the tonicity. What is the tonicity in different segments? So first coming to the PCT. The fluid is directly filtered from blood and it is sent here. So the tonicity will be isotonic. Isotonic. In the proximal convolutional tubule, it is isotonic. Even sodium reabsorption is done along with the water. So equal amount of solute as well as the solvent is there. So the tonicity here is isotonic. Now coming to the next segment, descending loop of Henle. What it does is, it takes off water only. So this tube is also called as concentrating segment. So this tube is also called as concentrating segment and it makes the fluid hypertonic. Now coming to the thin ascending loop of Henle. This thin ascending loop of Henle also will have the hypertonic solution only because it is not permeable to even water as well as the solutes. Then coming to this thick ascending loop of Henle. This thick ascending loop of Henle is permeable to solutes. Now what we are doing? From the hypertonic solution, we are taking some solutes out. So what will happen? This will become isotonic. It is going back to become isotonic. So in the thick ascending loop of Henle, it will become isotonic. Now what they do it in the DCT? In the DCT, again we are taking more solutes from the isotonic. Previously it was hypertonic. Now whenever we have taken it, it has become isotonic. When we take more solutes out of it, what will become? It will become hypotonic. That's why in case of DCT, it has become hypotonic. Now let's see what happens in the collecting duct. The collecting duct is not very simple because there is one hormone which is influencing in the collecting duct very much. This collecting duct, whenever there is presence of ADH, antidiuretic hormone. So if there is an ADH, what will happen? It will suck in water. So whenever it sucks in water from an isotonic solution, what will happen? It will become hypertonic. If ADH is absent, it will stay hypotonic and the urine will be very hypotonic. So first is isotonic, then it becomes hypertonic, then isotonic again, then hypotonic. Finally, it can become hypertonic or hypotonic depending upon the presence of ADH. So this I have to remember. It's very simple. Just remember what the segment is doing. Descending loop of Henle takes out water. Ascending loop of Henle takes out solutes. DCT takes out the solutes. Then collecting tubule we have to remember with ADH and without ADH both. Now so to summarize it, where is the maximum hypertonicity? Obviously the maximum hypertonicity will be in the loop of Henle in the descending part because it is taking up only water. So in the presence of ADH or in the absence of ADH, both descending loop of Henle will be hypertonic. But in the presence of ADH, even the collecting tubule will have severe hypertonicity. As you can see here, hypertonic and hypertonic written in these two places. So coming to hypotonicity, what is happening? Where is the hypotonicity? If ADH is present, then there is no question for the collecting duct because whenever ADH is present, it becomes hypertonic. We cannot say it is hypotonic. So where it is hypotonic? Only in the DCT. Only in the DCT. If ADH is absent, then it will be hypotonic in the collecting tubules. Now coming to some important notes of the tubular transport. Before going into the substances of tubular transport, there are several important notes that we should remember as a fact. These are very much important facts. So first coming to the most important segment, proximal tubule. Maximum reabsorption of many substances takes place in the proximal tubule only. So let's see what all substances are being reabsorbed here. 2/3 of sodium chloride, then water, potassium, urea, calcium. So 2/3 of all these substances, sodium chloride, water, potassium, urea, calcium, all of them are maximally reabsorbed here. Then there is one specific question where the students will constantly make mistake. It is asked, the water reabsorption is maximum if ADH is present. Where is the water reabsorption maximum? So the water reabsorption will be maximum it will be in the PCT only. And what is the reason behind it? The reason behind it is with or without ADH, already 2/3 is being reabsorbed here. 2/3 means that is 66% is reabsorbed here. Whenever ADH is released, it increases the percentage to a very little amount only. So don't get confused with collecting tubule or the distal convoluted tubule where ADH action is possible. Always go for a PCT because 66% is the maximum observable part which is done already in the PCT. So with or without ADH, still PCT wins. Now coming to the phosphate and bicarbonate. The phosphate and bicarbonate, 80% of them is reabsorbed in the PCT only. Now coming to the glucose, 100% of the glucose is reabsorbed in the PCT only, like 100%. So that is the reason why in a normal subject who is non-diabetic, we don't see any glucose in the urine. Whereas in diabetes, what happens? The load starts to increase and finally they will start appearing in the urine also. Then there is one more question, where is the magnesium reabsorbed? Because we saw maximum for most of the substance in the PCT. The magnesium is maximally reabsorbed in one portion, that is the thick ascending loop of Henle. So this could be a potential question because only thick ascending loop is the one which is reabsorbing maximum amount of magnesium.